Chair, we're now live.
Right, thank you, and good evening, everybody, and welcome to this evening's Overview and Scrutiny Commission meeting. One and all, as I might say, before we start, can I just mention a few words on the housekeeping? You all need to mute yourselves at the start of the meeting. Please switch on your camera when you are next to speak and say your name before you begin. Okay, thank you. And we therefore turn to item 1 on the agenda, which is the apologies for absence. Kirsty, do we have any?
We've had apologies from Councillor Tina Mackenzie-Boyle and Tracy Wright.
Thank you. Are there any others? No. Then we go to item 2, declarations of interest and the party whip. I don't intend on reading all of that out. We're all familiar with it. No. Urgent items of business. I'm not aware of any.
No, there are no urgent items of business.
Gemma. Item 4, public participation. Not aware of any.
I'm not aware of any public participation. Tricia Brown has raised her hand though.
Tricia?
Excuse me, thank you, Chair. It's just to note that I'm in attendance. I'm not on the committee list, but I'm here.
Right, thank you. And welcome. Now, with your agenda before you, we now move out of the Overview and Scrutiny Commission and move into the Strategic Health Scrutiny Committee. And this is item 5 on the agenda. And I'd like to start by asking Fiona Sevin-Brown. Fiona, are you there?
Yes.
Hello, good evening.
I am, Chair. Thank you very much.
Nice to see you again.
Nice to see you.
And if we can hand over to you, you would have already had, members did put some questions which you kindly answered, most of them before, which I've had with their papers. 2 I think still need picking up on. You'll probably pick those up in your presentation. But can I hand over to you to give us your presentation and update?
Thank you. Thank you, Chair. Can everybody see my screen?
Yes.
Yes. You can see it?
Yep.
No, I can't.
No, we can't.
No. Let's try again then. No?
And now.
You can now?
Yes.
Yep, thank you.
Perfect. That's great. Thank you very much. Let me just work out. Technology is a great thing when it works, isn't it? Okay, so hopefully everybody can see my screen. So I'm just going to run through a few slides.
Full screen. You might need to put it on full screen. We can see your previous slides.
Yeah, you're not in presentation mode.
Ah, okay. Give me a minute.
That's it. Thank you.
Better. Okay, good. Thank you for that. Okay. So I was asked to come and present to the Commission what the key issues were for health at the moment, and then I'm going to tell you a little bit about some of the specific capacity challenges that we've got at the moment and some of the things that we're doing to address some of those. So happy to take questions at the end, Chair, if that's okay with you.
Yeah,
I'll do the presentation. Thank you very much. So I think you'll know that we've still got COVID circulating in our communities, and we've done a huge amount of work with our colleagues in the local authority and the wider sector to help address some of that, so getting some really messaging out to the public. But despite that, we've got higher rates of infection in younger people. And obviously one of the concerns we've got is the risk that that presents to those who remain unvaccinated and those who are vulnerable within our communities. So that's clearly something that we're concerned about. There's also continued pressures across the board on our urgent care services. So our emergency department, the walk-in service at Brantsbridge, as we've talked about previously, our GP practices, 111, 999. You'll have seen a lot of that in the press recently about the particularly heightened levels of pressure on the ambulance services, and then they've recently been in business continuity. We've got to maintain all the infection prevention control measures in healthcare. So despite the government lockdown and Freedom Day on the 19th of July, things haven't changed in the NHS. So we still have to maintain social distancing. People are expected to continue to wear masks. So all of those infection control procedures have to be maintained. And that differs to most people's experience of other parts of their life. And that is causing some challenges. It also reduces the amount of capacity that we have. So we can't have lots of people gathering in waiting rooms or crowded areas. We've got to maintain that space, and it reduces the amount of flow that we're able to have through some of our main buildings. We have seen an impact on admissions recently into hospital of people with COVID following the recent increases, and we certainly are seeing some increases in respiratory infections in children. We're expecting this winter to be a particularly difficult winter. We've had lots of young children, lots of older people, lots of adults who in essence, have been protected from the normal circulating viruses. And we expect a lot of those to be around this winter as people start to congregate, start to come together with their friends and families. So we are expecting to see some increases in the normal seasonal infections. Our GP practices are continuing to experience very high and increasing levels of demand for access, particularly urgent care. So we've seen an increase of 17% between last month and this month, and that's been happening for the last 3 to 6 months. So some of our practices are seeing, up to 100% increase in demand on the day. Our practices are continuing to support vaccine program and those people in our community with long-term conditions and those who are more vulnerable. So there's a huge amount of work our practices and are expected to manage at the moment. And alongside that, there isn't any particular huge increases in capacity, although we have invested in general practice over the last couple of months to help support them where they can bring in additional workforce to deal with that. Increased and sustained demand for mental health services. So we've seen an increase in children and young people presenting with eating disorders or disordered eating, and adults and children needing urgent mental health support. And we've seen that across the board. So I'm sure Gordon will talk about that in terms of social care, but there's been that increasing demand across the board. We've all seen that direct and indirect impact on our communities. So long COVID, we're expecting those numbers to increase, people waiting for treatment, increased safeguarding, and obviously the impact that COVID is going to have on the wider determinants of health in our communities. And I'm sure colleagues will touch on that. And concerns remain over the resilience of our workforce. We've had a workforce, and you'll know the pressures on the NHS since January, February of last year have been immense and unprecedented, and our staff have been absolutely phenomenal in their efforts to cope with the pandemic, look after patients and care for residents, and continue to do their best and come into work every day despite all the challenges that they've been facing. And so it's not unexpected that some staff are exhausted. And obviously we're trying our best to support staff wellbeing and make sure people have their holidays so that they are refreshed to be able to deal with what we expect to be a further difficult period for the NHS and for partner organisations over the coming months. So I thought I'd just give you a few kind of headlines, and you've all seen these slides in your packs that came out. But as I said, we've seen a steady increase in emergency attendances since January, and we're now at levels that exceed where we were before COVID. All our places, so all areas in the Frimley system are seeing activity levels at or higher than pre-COVID. For Amber, and Amber is those patients who it's not a trauma, it's not at the very acute end of emergency medicine, but it's more significant than a minor ailment or a minor injury, so in that kind of middle category. And our urgent care centre at Brantsbridge is very well utilised, so we're getting lots of people who are coming to use the minor injury service there and the minor illness offer that's available there as well. And we've been doing a lot of work to put good messaging out to our public through Town and Country, through social media, to ensure that our local residents know where to go and what to do if they need support. Primary care, so I've talked a lot about that already, but our GP practices in the area are preparing now for winter. They have provided a lot more appointments online and virtual and face-to-face. So almost just over 4,000 additional appointments have been made available since the 1st of June for our patients. But they're, as I said earlier, they need to continue to work along with or in line with those infection prevention control and guidelines. So I appreciate that for some of our patients that might feel really frustrating, but at the same time, we've got to try and support our practices in working to those infection control procedures. We're recruiting some additional roles into general practice, so you'll know that we already have paramedics, clinical pharmacists, extended scope physiotherapists, but we're also looking to recruit care coordinators. We've got mental health practitioners, all working as part of that primary care multidisciplinary team. And our communications team are working with our practices to make sure that what's available to our residents on their websites and their Facebook pages and the other means of communication through patient participation groups is really good, up-to-date information, so that it's consistent, because I think that's going to be really important. But the key areas that we're focusing on are mental health, learning disabilities, people with long-term conditions, particularly people living with diabetes, hypertension, respiratory illness, focusing on making sure that we're referring people when they need help, for example, suspected cancers, continuing with health screening, so smears and bowel screening, and also we're continuing to deliver the vaccination programme, not just COVID, but obviously the routine vaccination programme. And from September, we'll be delivering both a COVID booster and the seasonal flu vaccination. So that will come online from the 6th of September up to just before Christmas for our residents. Elective care, and what I mean by elective care is planned surgery. So if somebody needs to go in for an operation, then what we're working on at the moment is addressing waiting lists. So making sure that we're trying to reduce the number of people who are waiting, particularly those people whose clinical need is greatest. So we use a prioritisation approach to ensure that we address people's needs as quickly as possible through that. But we recognise that waiting lists have grown during the pandemic. There was a time when we had to put all our efforts and energies into supporting people with COVID when we were under extreme pressure. And a lot of the clinicians' time was needed to be focused on those most poorly and sickest in our hospitals. Cancer referrals in our area are back to pre-COVID levels, and in fact, we're performing much better than a lot of other areas around the country in terms of cancer waiting times. And we are increasing the proportion of outpatient appointments that are now being offered by telephone or video, particularly routine follow-up appointments. But we're in a much better place in terms of referrals from general practice, which have now returned to pre-pandemic levels, which is great. Mental health services, I've mentioned before that we've seen an increase in demand for eating disorders and crisis services. So there's a lot of work going on to put in additional capacity and additional support in those areas. But we've also seen increased demand on our acute mental health beds. with very high levels of occupancy and a small number of beds available. So there's a lot of work happening with partners around admission avoidance, so keeping people well and supporting them to stay at home with their families or their carers. And at the same time, if somebody is admitted to hospital, that we can help support them to be discharged as quickly as safe to do so. We've also got new mental health support teams in our schools locally. So that would provide additional support for our children and young people. And there's a significant amount of resources that we commissioned together with council colleagues around Couth and Youthline to support our young people in a proactive way. And that's something I think we should really celebrate locally. Community services. So we've got social prescribers in place across Bracknell Forest, work very closely with our public health colleagues, our PCNs and our partners to support our residents. For example, we've been carrying out 8-week wellbeing checks on people recovering from COVID following intermediate care support, and that's a fully integrated health and social care offer for our communities. And I think it's another area that I think we should really celebrate. We are continuing to work together with our colleagues and partners to establish our 2-hour urgent care response offer. And we already have a 5-day-a-week community geriatrician advice line available to support our health and social care teams if they need help with an individual patient. Our Heathlands Care Home project, you will know already, is progressing really well and on schedule to come online later in the year. And that will enable us to provide 20 health beds in the middle of Bracknell, so it'll enable our own residents to be cared for close to home. And if they've had a stay in hospital or they need a short stay in a community setting, that they're able to be admitted there without needing to go to St Mark's or slightly further afield. So I think that's fantastic for our residents. And then one of the questions you asked me, or a question that came to me, Chair, was about Brantbridge and what's happening at Brantbridge in terms of activity. So I just thought I'd share this with you. It's over 2 slides now, which a little bit more complicated, but I'll bear with it. So on the top of this page, what you'll see is what was provided in terms of activity pre-COVID at Brantbridge. And then on the next slide, what you'll see is what we're doing at the moment. So in terms of the total capacity that was provided pre-COVID per month, it was 1,815 appointments. And where we are now is we've nearly doubled that. We've got 3,650 appointments available for our residents. And that's a combination of a minor illness service, which is available via an individual's own GP or via 111, and provides a full range of offers, including a home visiting service, which wasn't available pre-COVID. So we now see up to 395 appointments per month, which allows us to visit some of our most vulnerable patients in their own homes, an acute minor ailment clinic and a twilight clinic. And the twilight clinic's really popular with parents of young children because they find that they can take their child there after school or nursery, or when they're home from work, then they can take the child there. So it's really, really popular. And then our minor injuries clinic, which is both you're able to get booked in there via 111, but also now available via walk-in. And we've done some work with the ambulance service, and paramedics are now also able to book people in to come for clinics, and also our GP practices. So reception staff can also contact the minor injury service and get people booked in there directly. So that's a real, as I say, think success story. We've really changed the way that looks. And the feedback we've had so far, and I think I shared some feedback with you previously through when Rachel and colleagues came, that we've had some really positive feedback. I think it was almost 90% satisfaction rates from those residents who have accessed the services there. So I think that's fantastic. So in terms of what next, I think one of the areas that we need to focus on, and we'll continue to do so with our partners, is on health promotion. So helping and working with our communities around how staying well, how to look after themselves, and then knowing where to go and how to access the support they need when they need it, but also continuing to look at the way that we offer care, working towards a fully integrated model, so health and social care working together with the voluntary and third sector to provide a integrated and wraparound support, and really taking on board the views of our communities in terms of what their needs are and how we might best work together to support them. So that's my presentation, Chair. I'm very happy to take questions from colleagues, but I know Grania also has a presentation, and Dale, I'm sure, may have something he wants to add, but thank you for that.
Thank you, Fiona. I think perhaps at this point, shall we take questions to yourself first, and then we'll come on to the other presentation as we work through.
Very happy to.
Thank you. Councillor Mrs. Temperton, your hand is up.
Yes, it is. Thank you very much. Thank you for that, all that information. It was much appreciated. One of the frustrating things, and I'm going to ask, will the GPs have more help in getting their phones answered? Because most residents get so frustrated if you're 2 minutes past 8 o'clock, you're number 36 in line, and then you're told there's no more appointments for today. And even when you're on 111, and I phoned them in desperation the other morning at 7 o'clock, trying to get a doctor's appointment for my husband, even that I had to wait 20 minutes. And then after inquiry and everything, he said to me, you need to get an appointment with your doctor. Well, and also, so we need more people answering phones so that actually because I think people are giving up. And I think people are actually, they may be in real serious problems and needing to see someone or needing to talk to someone. But when you're told you're 36 in line, they can't they just give up. And also, I must say, I understand the doctors and everything, but and they can't let anybody in their waiting rooms. But surely they could have provided some sort of shelter outside their door. When an 86-year-old man is standing there in the pouring rain for 25 minutes for an appointment that was there and he's booked, and he's having to wait there and having to stand because there's no seats provided. Other places do provide seats and then wipe them down. I run a community centre and we've opened it up and people wipe them all down and all the rest of it. You're not allowed in at the prevent, but you have to stand. My own husband, I took him to the doctor with a very bad leg. He couldn't walk. And we were standing there for 20 minutes outside with no seat in, and you know, a shelter, 4 poles and a bit of plastic, or a tent or a gazebo would have actually made it much, much better for the residents and shown that the doctors actually understand how the frustration of standing there in this long queue waiting to actually try and get in. Thank you.
Fiona, would you like to respond?
Yeah, I mean, I think those are really important points that Councillor has raised. I will take those away. I think the point about the phone lines is something we're really conscious of. We've had that feedback. Health Watch did a survey recently of GP practices across East Berkshire. And one of the themes that came through from that was people struggling to get through on the phone. And I think it's much more difficult to get through on a Monday and a Tuesday, is certainly what we're hearing, is there are very much peak times. And also, I think colleagues' point there about appointments being booked and they have to then don't know when the next available slots are. So there's something absolutely for us around how do we swap practices with their call handling. And then the second point about shelter, I totally support that. I will take that away. You know, I would expect that we will be allowing some people into our waiting rooms. It will vary by practice, because I'm sure colleagues will know that we have 1 or 2 practices that are very, very small and a very limited indoor space. But that's not to say that we shouldn't look exactly at the type of thing that's been suggested. Where is there some kind of lean-to, you know, temporary structure that can be put on to help support keeping people sheltered, particularly as we get back into the winter period. Yeah, thank you. I'll take that away, Chair.
Thank you. Councillor Virgo?
Thanks, Mr. Chairman, very much. And thanks, Fiona, for all the information. There is a bucket load of it. And I just want to say at the outset is that we all appreciate that this has been a really difficult time for everybody in the health service. And, you know, there are some many good things to say thank you for. So if I'm going to criticise some things here, I have to say thank you so much for the brilliant inoculation and I know everyone's worked together, and I think that needs to be said. I think we've been absolutely world class at that. So I wanted to say that up front, Fiona. The criticism I have really is the urgent care centre, and we could talk about mental health for a long time, and I know that the new chairman is going to concentrate on that, and therefore, you know, I don't want to spend time talking about that in this session. But it's the urgent care centre that I have particular criticism about. Now, in terms of questions, we didn't really know that it was going to close, and we would have appreciated much better feedback as to what was going to happen. That's the first point to make, I think. The second point is that it has been downgraded. And when I say downgraded, it's been run by senior nurses and not a medic. Now, I want to know why that decision was taken by the CCG, because the whole point, Fiona, and I'm sure Dale can speak up for this too, was that I sat with him and fought many battles, particularly with the Royal Borough of Windsor and Maidenhead, where it was going to go to Heatherwood Hospital. And in fact, we got it in our borough. But one of the points that we made at various stages was that we did not have a hospital. We didn't have an urgent care facility for 120,000 people. And therefore, we were in the middle of a triangle. And the idea of an urgent care centre was exactly that. It was to go halfway to say that you've got a medic and you can supply a level of service. That was not a minor injuries, you know. The minor injuries was at Heatherwood, but when we transferred it to Brandsbridge, it was in fact staffed with a medic. Now, I would ask a fair lot of questions here. The first point, are we still dealing with the same outsourced company, which was First Medical, which I understand was in Yorkshire? That's the first point. The second point is really, why did we downgrade it? And if we did downgrade it, which we obviously have, what was the thinking behind that if it wasn't just finance? And the third point is, we weren't told that really. We weren't consulted. It just happened. And to finalise my points, I went to Brandsbridge to look on the outside, and we had a conversation, I think, actually on the phone personally. And to be honest, there's so many signs up there on the doors. It really is a mess. Now, it doesn't take a lot to make that better, to be honest. You know, a bit of clearing out, a bit of focus, a bit of what we want it to do, and so on. It could be done this evening. And I'm disappointed that that's still the case. And very lastly, I do think it's really important, where I think Mary Templeton has made this point, but it needs to be made very clearly. We all understand the pressure in GP surgeries. We understand that. But it is really difficult, Fiona, for a lot of people to get appointments and to get into GP surgeries. That's a fact. And so what the urgent care centre was there for was to take that slack so that people don't drive actually to A&E in either Frimley or Wexham Park, to save that amount of facilities. And therefore, I can't quite see why we've gone down this path. Now, I know there's lots of questions there, so forgive me, I thought I'd put them all together.
Thank you, Councillor Virgo. I might need you to repeat some of your questions. I've been scribbling like mad trying to catch them all, but I suppose a couple of things from me. The workforce that are in the Brandsbridge service are the same workforce that were there pre-COVID. So we haven't changed it. We haven't decommissioned anything. We haven't taken anything out or stopped anything. In fact, it's exactly the same workforce who are working to the same service model that they're working to previously, but we've upgraded, I think, some of the offer around the minor illnesses. So I just wanted to correct you on that. That hasn't changed. So minor injuries would never have gone to a GP practice. They'll always be seen in Brantbridge or in an emergency department. So in terms of overflow for primary care, that's not what the minor injuries service would have ever offered to our GP practices. However, there was certainly an offer when it came to minor illnesses, and our practices are now using that themselves directly for accessing support when they don't have available slots at the practice. And you can see that we've now got those additional 1,700 slots a month available to support our practices. So that's really quite significant. And those previously would have been accessed, and I think this is important to note, by when there was a walk-in aspect to minor illnesses, 40+% of the activity that would have been seen at Brantbridge were Wokingham patients, because they would have been able to just walk in, and that unit would have seen patients registered across wherever, basically, because it was a walk-in service and it was commissioned as such. Actually, we've got a dedicated Bracknell minor illness offer there for Bracknell residents, which is excellent. And we've got a minor injury service that is open to our residents and other residents around us, but primarily is used by Bracknell residents, which again, I think is important to make that point. So on the downgrading point, I dispute that. I think it has actually been downgraded. I think in terms of the signage, absolutely take your point on that. I've been there myself many's a time. I think it is quite confusing. I think one of the challenges is it's a building that has multiple different occupants, of which the urgent care centre is only one small part. The vast majority of the services there are provided by the Royal Berkshire Hospital, and they own the building. But I'm very happy to take the conversation around signage back with my Royal Berkshire colleagues and ask for their help. We have updated the signage around the, just to make sure it's very clear that the service is open to minor injuries, and probably welcoming colleagues to come in. And it's very, very well used at the moment. So I just wanted to also support that. Actually, there's no lack of uptake of the service. As I said, I think that's really important. I do accept that it's difficult to get an appointment at people's GPs. I think, as I said, given the numbers of additional calls that our GPs are getting every day, and one of our practices, interestingly, said that on a normal Monday they would have 300 inquiries, and on a recent Monday they had 500 inquiries on one day, and they're trying to deal with that with the same amount of staff. So I think that's just context. It's not an excuse, but it just gives us, I think, a bit of a flavour of the challenges that primary care are facing at the moment. And I can't remember, Councillor Virgo, was there another question that I haven't answered?
Yeah,
I'm happy to answer.
Yeah, of course. I just want to go back to this because I'm totally and utterly confused, Fiona.
Yeah.
I sent an email to your office, you were away actually, and I asked what was the difference between minor injuries and urgent care. Because I looked, for instance, to Hull. I just picked on Hull. I don't know why. I think I decided to. And they have an urgent care centre which is open much longer than ours actually, but it's open 7 days a week. Now that's fine. But it's still operative. So I don't quite understand why we've now called it a minor injuries, because I remember a long time ago, Fiona, and this is not criticism to you, but I remember arguing this in the Overview and Scrutiny Committee, that urgent care is terribly confusing because we have people will think that's A&E. And the NHS decided to go with urgent care. So it's really confusing for those people that then think, okay, it's urgent care, and now we call it minor injuries with no explanation as to why we did that. Now, just one other point. In the email that I was sent from your office while you were away, they said that the difference between urgent care and minor injuries is that urgent care is staffed by a medic and minor injuries are senior nursing staff. So if you've got the same staff and it's still supplied by First Medical from Yorkshire, I don't quite understand why we changed the name.
It's okay, Chair, if I come in on that. So
yeah, sure.
It is still called the Bracknell Urgent Care Centre. So just for clarity, the name hasn't changed. That's exactly what it's called. The services that are in there are the same types of services that were provided pre-COVID. So hopefully I'm making myself clear on that. The definition of urgent care is a broad and wide one, I would say. So our urgent care centre provides a range of services for our community, including minor injuries and minor illness. So it has both co-located on the same site. So I think we've hopefully clarified that in the last couple of weeks. We've changed the signage, we've put communications out to the public. And as far as our public are concerned, what we really want them to do, and we've said that quite often in our comms, is phone 111 or use 111 online to get assessment. Phone your GP. There's a very clear know where to go. If you see the infographic that we use that was in Town and Country, hopefully that makes it very clear for our public about how knowing where to go and what to do when they need support. And I think that's a message we want to keep giving out. People shouldn't need to worry about whether it's a call to this, it's a call to that. What they need to do is, where do I go to speak to somebody who will help guide me to the right place, so I can get the help I need as quickly as possible. And that's what we've been trying to put out in all of our messaging. So I'm very happy to share that messaging again with the Commission, so that you can see the types of messages that we're giving out to our public, in the hope that people are clearer about knowing where to go and how to access the care they need when they need it, because that's what's really, really important to us. But I absolutely welcome your feedback.
Could I just end this, because other people will want to go, I think. But do I understand from this conversation that there is a medic currently in the so-called urgent care centre?
No, there's not a full-time medic on site in the urgent care centre.
But there wasn't. That's the point I was trying to make, because in the previous contract that you had with First Medical, there was a medic all the time in there, because I used to go in there, to be honest. And that's, in my view, has been downgraded, Fiona.
Yeah, I'll have to go away and look at that, because as far as I'm led to believe, it's the same staff that are in there now that were in there pre-COVID.
So it can't be the same staff, with respect, if you don't have a medic there all the time, can it?
I'm not aware that there was a medic in there before either, Councillor Virgo, so I'm very happy to go away and look at it.
There was a medic, because it saved my life. So there was a medic. I know I'm being over dramatic, but he was extremely good in very tight circumstances, but there was a medic on duty.
Okay, I'll take that away, Chair, and look into it.
Okay, I'm grateful. Thank you, Mr. Chairman.
Fiona, thank you, Councillor Virgo. Fiona, I wonder in due course, when you've had a look at that, whether you could correspond with us and let us know the answer.
Of course I will, Chair. Through you.
Thank you. Yes, please. And if I may, just before we move on to Councillor Mrs. Mattock, can I just ask that you talk about the number of phone calls gone up from 300-ish to 500?
Yeah.
Is that purely because of COVID? Because that's an awful big increase, isn't it?
Yeah, it's not due to COVID or people having COVID. We're not really 100% sure why, but it's something that's being seen across the country. I suspect it's a combination of things. I suspect it's due to people holding on to their problems during COVID because they don't want to burden the NHS. They're worried about, troubling the NHS when the NHS is dealing with COVID, and they now want to come and talk to somebody. There's health anxiety. I think people are a bit worried. They haven't been able to see somebody. They want to talk to their doctor or their nurse. I think there is a bit of unmet need. So people, as I say, who maybe need a review, need to be seen, need a prescription updated, need to have some care. And then there are obviously still patients in our community who've got COVID and who we're continuing to support. So I think it's a whole combination of things, if I'm honest, Chairman.
Can I just ask, within your area, has there been a reduction of GPs? Because there is a perception that, that there aren't as many GPs, or perhaps not as willing as what they used to be, to make themselves available. And a number of them are indeed part-time, for want of a better expression.
Yeah, I would certainly say that nationally, there's a major campaign to try and promote general practice as a career and to recruit more GPs. You'll have seen that in the press nationally, and we're doing that locally. So we do have new GPs joining our practices all the time, but we also have a group of our GPs who are due to retire in the next 5 to 10 years. And in some practices, that group outnumbers the younger group coming through. So I would say it's definitely a challenge. And that's the same for nursing and other professions where, there's a retiring group of professionals that we're continuing to work to recruit replacements for. I think there's also a change in the demographic of GPs. So it used to be fairly male dominated. There are now more women training as GPs than men. And a lot of our female doctors will have families, will have caring responsibilities and want to work part-time or want to work flexibly. So I do think it has changed as a profession over the last maybe 5 to 10 years, but we're still attracting some excellent GPs to want to come and work here because it's a nice place to live and work. And we're also attracting lots of other professionals to want to come and work in general practice. So paramedics, clinical pharmacists, physios, etc., who want to become a part of that multidisciplinary team. And I think you provide a vital role in supporting our patients. So I know myself, I've accessed a physio through one of our GPs in Bracknell, and it was fantastic. I was able to go to the practice and see a physio and have treatment. And that was a really good use of that clinician's time. And it was really handy for me to be able to have that. So I think there's lots of ways we can expand the workforce as well as recruiting really top class GPs into our area.
No inside influence there, was there?
No.
Councillor Mrs. Mattock.
Thank you very much. That was really very interesting. I just really wanted to raise a couple of points which you may not be aware of. A friend of mine, she had a very bad pain in her foot and she was really worried about it. And she was sent for an X-ray and she was sent to Heatherwood. Well, I took her and was in and out in 10 minutes. This was a Monday morning, and they were told that the doctor would receive the report by Wednesday and to contact her doctor. Well, she constantly tried to get hold of her doctor and couldn't. And it went into the next week and couldn't get him. In the end, she was told to ring her pharmacist who would give her the results from the X-ray. How about that?
I'm not really sure what to say about that, Councillor Maddock. I don't know whether you want to email me offline or somebody wants to contact me. I'm not sure I can comment on specific situations because I don't know all the details, unfortunately. It sounds very unusual. I've never heard of that happening before. But I'm sure if your friend would like to contact us directly, I'm sure we could look into it for her.
I'll see that, but just interesting. The other thing is, I think it was my doctor's surgery that you were talking about, because those numbers are very familiar, and I'm chairman of the patient group. My experience was I badly needed a doctor's appointment urgently. I phoned up at 2:30 on a Monday afternoon. Come 2:45, I had a text to say I had an appointment with a doctor at 10 to 5. Fine. And then I got my tablets. I then had a serious reaction, and it was either change of medication or end up in hospital. And my doctor, who was actually on leave, he actually sent off a new prescription for me, which actually saved me all that problem. So, people are working through that, and I was very grateful for that happening. And I've not had any trouble. I phoned my doctor twice yesterday, no problem. So
thank you. It's great to hear you had a good experience. That's really positive. So thank you. I'll take that, because I think, as you say, I know personally, as I've referred to, Chairman, I'm also a patient of a practice in this area, and I've recently had a very good experience of that particular practice. But I do recognise that's not the same for all of our patients, and it's important that everybody has the same positive experiences. Councillor Mattock and myself have both reflected. So I think I'll take all those earlier comments away.
Thank you. Councillor Birch.
Thank you, Chair. Councillor Jill Birch here. I was just actually going to say I was really pleased that we're continuing to have Frimley ICS, and I just really wanted to ask you actually a question about, I know there's been lots of changes in the health service, and I just wondered how things were at the moment. Are things stable, or are there lots of changes going on? You know, we've heard about, we were worried about Brandsbridge and whether it was an urgent care or whether, and the definition. So I really wanted to ask you about the state of things. How is it? Is it in turmoil or is it settling down?
So in terms of how things feel from a service delivery point of view, Councillor Birch, I would say it's still very busy. People are working very, very hard. There are going to be, I think, we're planning for winter and all that comes with that. So that, of course, keeps people very, very busy. Alongside that, in terms of the strategic conversation, so the national picture, we've got a new chief executive of the NHS that's just been appointed very recently, the first female chief executive of the NHS, of which I personally am delighted so to replace Sir Simon Stevens. So that obviously new leadership will, I'm sure, bring new ways of doing things, but I'm really looking forward to her leadership, because I think she's been excellent throughout COVID, and she had a very public role during the pandemic in terms of her interaction with us kind of frontline NHS people, which was fantastic. And I think then the ICS, as you say, that was fantastic news for us. We're absolutely delighted to be able to stay as Frimley ICS, and for Bracknell and our as a team, and I class us as a team, myself and Dale and Grania and colleagues, we all work together, that we'll be able to continue to work together and really get the benefits from being part of this system for our residents in Bracknell, and being able to influence some of those conversations at a system level to the benefit of our communities. I think that's going to be really important. So I'm hoping any changes will further enhance the benefits that we've seen of being part of the Frimley system. But as you know, the CCG will, the ICS will become a statutory organisation from the 1st of April next year. The white paper just went through Parliament very recently. So the CCG will no longer exist as a statutory entity, but ICSs will. But I think that will bring a much greater opportunity, because, and I don't know whether colleagues have seen the white paper, but there's a very strengthened emphasis on partnership and integration within that, and the voice of communities. So I think that will just further add value to, as I say, what we can do for our communities locally. So I'm really positive about it, Councillor Birch.
Good, thank you very much. Thank you.
Thank you. Councillor Brown.
Thank you, Chair. This is prompted by something that Councillor Mrs. Mattick was saying, and that is that lots of people, and I have the same problem, I must admit, are their doctor is retiring and they're not allocated to a specific doctor. They don't know how much of their history the doctor that they see will know. I think it would be impossible for them to catch up on some people's history. And they don't even actually know where they're going to be sent to see the doctor, with a larger conglomerate of practices all being shoved into one. To be honest, I'm quite nervous about going to the doctor at the moment, because my doctor retired some time ago. I haven't been to the doctor for ages, but I know that if I saw her, she would know what I was on about. And it's going to take a while to build up a trust with the doctor. And I think this is all breaking down, and there are a lot of people quite fearful about it.
Fiona, would you like to comment?
Yeah, thank you, Chair. Thank you, Councillor Brown. I think on the back of that comment, Chair, it might be helpful at a future commission if we came back to talk about the plans around the development of primary care networks, because I think that might be what Councillor Brown is referring to, is practices coming together and working together to support each other in providing high quality care. But I think you're right in the sense that they're working much more closely together, and therefore it might be that people would go to a different site, for example, to access, you know, a particular service that's available on behalf of a group of GP practices. So I think that might be a good thing for us to touch on at a future commission, if that was okay with you. I'm very happy for us to come back and maybe a couple of our lead GPs come and talk to you about that.
That would be excellent.
That's one thing I must admit it would be really helpful, but people are not being allocated to a single doctor who sort of knows all the issues and can refer you to the right place depending on the issue. I mean, all the things that you suffer from are related in some way, and somebody's got to know about that and be the expert on it, surely.
Yeah, I think the expectation is that everybody has a named GP. I think in practical terms, whether you get to see that named GP every time you want to see a GP is quite practically quite difficult, if I'm honest, because obviously you've heard me say about the demands that practices are under. But I do think that you will have a named GP. I know I've got a named GP, and I think our GPs are very conscious of, particularly people with complex long-term conditions, making sure that there's continuity of care is really important. So that's something that they do work very hard to try and do, is maintain a contact with individual patients, particularly those with most complex needs, but that's not always possible in every case. So I would accept that.
That's due to shortage, I guess. So thank you for that.
Okay, thank you, Catherine. I'm not seeing any more questions. Are there any more? Nobody's got their hand up. Looks like you're going to get away, Fiona. Can I just say thank you very much for...
You're welcome, Chair. Thank you.
And the time that you're offering and what you've spent with us in the past and today. It's when we're talking to residents who obviously we're concerned about,
of course,
utilisation of what's going on, that we can say with confidence. It may be not what they want to hear sometimes, but you know, our knowledge is a little bit wider now than what it was at 6:30. Put it that way.
Thank you, Chair. Are you okay if I stay on for the with Grania and to Mr. Grania?
Oh, absolutely, absolutely.
And then I'll leave. Thank you. Thank you, Chair.
More than welcome. Then we turn now to Councillor Birch. Now, are you there? And you're talking.
Thanks. You did.
Wellbeing Board.
You did scare me when you called Councillor Birch out earlier, I must admit. But
the voice has got deeper.
Panic. No, thank you, Chairman. It actually says will explain how these issues are being considered by the Health and Wellbeing Board. Given the huge breadth of Fiona's input and the questioning, it's certainly not my intention to go back and visit all of those issues.
Thank you.
But yeah, no, there you go, folks. But the Health and Wellbeing Board for Bracknell Forest is constituted under the relevant act. I think it's 2012 when Health and Social Care Act came in, and it's one of its primary roles, there's a number of roles, is to drive integration within the system. And that's not just within the health system, that's within the health and care system, however care is defined. Now that includes public health, that includes assisting in and helping with the integration of the voluntary sector and so forth. And so it pulls together on a voluntary basis. It is not a statutory committee yet. It's a committee of the council, but it does not have its own budget. I was asked one time to present on the Health and Wellbeing Board's budget proposals, etc., etc. And I had to remind the member that the Health and Wellbeing Board does not have its own budget. What it does is have an overarching responsibility to look at the partners and ask the important questions of how are the services that we've all agreed within our health and wellbeing strategy, again, a responsibility of the Health and Wellbeing Board, how is the funding going of their and our priorities. And those partners, by the way, include Bracknell Forest Council, clearly, the CCG, and I'm blessed by the fact that I have Fiona Slevin-Brown as my vice chairman as well. So that continuity and relationship between health and care is there. We also have Involve on the Health and Wellbeing Board. And one of the things I'm always keen there to make sure all the partners understand is the difference between charity and volunteer, the charity organisations and voluntary organisations, and how partners shouldn't just view the voluntary sector as an access to some low-cost resource, and Involve punch very much above their weight in making sure that they're properly considered within all the health and care hierarchy, and the Health and Wellbeing Board gives them the opportunity to continue to establish that. Now, that has been important, and I'm linking this back, will explain the issues over the last year, 18 months. It's been important that we, all the partners, understand how our voluntary partners and colleagues have been able to put up the amazing responses that they have, and some of them have been able to keep going through these very difficult times. And we've been able to hear how that has gone on, etc. The Mental Health Trust, Bracknell, the Berkshire Health Foundation Trust sits on the board, and of course we focus, and I know the Commission is going to focus very soon through the excellent new chairman, Mike Gibson, on mental health. Well, we, the Health and Wellbeing Board, have for a number of years looked very closely at mental health, particularly children and young people's mental health, and we will continue to work with the Berkshire Healthcare Foundation Trust in that, and the other partners that make up that complete mental health spectrum, because as you know, children's mental health is set up in 4 tiers. We also have the Frimley NHS Trust, as you would expect, on the board, and of course we've been getting the updates over the last year, particularly at the last meeting over the ICS, the Integrated Care System, and I was more than pleased to be asked at the meeting on the 8th of June to write to the Secretary of State, making a very clear submission to the Secretary of State that all the partners in this ICS did not want change. If it ain't broke, don't fix. It was the tagline, if you like. But we made a very strong case, Chairman, for the Secretary of State ministers to understand just how much work and how unique this integrated care system is in its integration. And I'd like to feel that it's that relationship within the Health and Wellbeing Board, and also that the Health and Wellbeing Board has projected out into the Frimley ICS through our fellow, my opposite numbers in health and wellbeing boards in Slough, Windsor, Maidenhead, etc., that has assisted in getting that tight knit, that tight bond of relationship and integration within that. Health Watch I've mentioned. We have Health Watch on the Health and Wellbeing Board, and they're invaluable for feeding back. As you will have heard, they just put in their latest report with some of the feedback from the important people we're all serving, and that is the patients and our residents. And there's some excellent work, and I commend it to members. If you haven't already seen it, go and have a look at it. It is very informative. We mentioned the primary care network. That's all our GP practices. Well, they're represented on our ward, on our board in the shape of Martin Kittle, and I think a lot of members on the commission will know Martin Kittle, a real tour de force when it's putting patients first. He has a big thing about long-term conditions and so on and so forth. At the last Health and Wellbeing Board meeting, the Health and Wellbeing Board wanted to know from partners, primary care network in this case, how waiting times and getting through to a GP, etc. And they came along to the Health and Wellbeing Board and gave a thorough briefing on how the primary care networks have changed and will change, and the effect of COVID on them, and how they are working back out of that. And of course, one of the things that is still contributing to increases in volume of work is that a lot of us put our ordinary ailments on hold whilst COVID was going on, right? And then as soon as the pressure on COVID and hospital came, we started back to pick up the phone and say, do you remember my problem with, etc., etc. So there may be the fact that the things that people put on hold are now coming back to cause that pressure in the system. And we'll, at the Health and Wellbeing Board, through our public health people, we'll be looking at those sorts of phenomena as part of a partnership. I mentioned public health. Of course, Stuart Limes, the Berkshire Director of Public Health, and our own Charlotte sit on the Health and Wellbeing Board, because the Health and Wellbeing Board is responsible for the Joint Strategic Needs Assessment. And that is a document that's masses and masses of data. And that feeds a lot of the commissioning that goes on within social care and also goes on within our care partners and our health partners. So that's the Health and Wellbeing Board is, if you like, the custodian of that. And the other element of that now is, and it's been on hold during COVID, is we need to refresh our health and wellbeing strategy. And one of I nearly said the word benefits, but one of the good aspects of the last 12 months is it has allowed all the partners to look very carefully and in detail at their forward plans. And I'm hoping over the next 6 to 12 months, that will allow all the partners to be able to better align their plans, thanks to having a cleaner point at which to start them, so that we can then, as a Health and Wellbeing Board, and I'm anticipating the Health and Wellbeing Board having more statutory status out of the new health and care regime that's coming out, the next Health and Care Act, etc. So I'm expecting us to have a bit more of that, because involvement and integration. We also have the Berkshire Care Association on, and we have our representatives from the safeguarding boards. That's very important. And on the board also, and you've heard them mentioned earlier, because God knows how they've performed so brilliantly. But the ambulance service, South Central Ambulance Service, also get to understand and hear how all the partners are working together. That makes up our Health and Wellbeing Board. And what we've now got to do is pull it all together, look at how each of our partners is standing back up the services that were closed, right? They were closed like the urgent care centre because of COVID, right? And I will challenge that. We were told that because of COVID, we needed to cease activity there, because that place was where and is where people receiving chemo and such dialysis and such highly specialised support need to go. And so that was the absolute health-related, inverted commas, reason why. And those people that were working in there were needed to be redirected. And that was the reason why that shut. And we were advised, because one of the things that the Health and Wellbeing Board does, and I know Fiona's there, but she won't mind me saying, the NHS doesn't do comms, public-based comms, that well. Councils have a better understanding of the language that's needed to get things across. So one of the things the Health and Wellbeing Board has been able to do is to assist our health colleagues with getting some of those very difficult messages that we've had over the last 12, 18 months out into the public domain in an understanding, jargon-free, and relevant to our residents' way. And the Health and Wellbeing Board helps that. And we've also been able, I've been able through representation on the Frimley ICS Alliance Board to hear all the comms planning that they're doing and be able to then interpret it into the necessary language that we need to inform our residents. And in fact, I have a regular Health and Wellbeing Board chairs meeting with our comms people here. And you'll have seen recently that we offered a page in the town and country to the CCG to get all that information out into every home about the urgent care centre and so on. And that's an example of the Health and Wellbeing Board doing its job properly by assisting all the partners in their work. And when it comes to money, I'll finish on this one. The Health and Wellbeing Board does not have its own budget, but we are very much aware of funding streams within the whole of the system. And where our funding streams are as a council and the funding streams of the NHS start coming together, and our own public health, etc., then we have what's called the Better Care Fund, and we keep a tight eye on the projects that are initiated, etc., and we get reports and updates on that, so that we can ensure that what our partners are planning to spend their money on remains focused on those strategic objectives that we've all got and stays focused on the needs of our residents. That's what we do. And I'm looking forward to having the role of the Health and Wellbeing Board enshrined a little more firmly in legislation as the ICSs strengthen, and as we see the role of the NHS's place committee taking shape as well. Thank you, Chairman.
Thank you, Dale. Dale, just a question. How often does the board meet?
4 times a year.
Is that
or quarterly sort of?
Is that sufficient, do you think?
At the moment, yes, because the way I established it was, and I hope members will understand, I don't like just turning up for meetings. I like meetings that decide things. And so the items that come onto the agenda for the board are usually those that need either a decision or need all the partners to have a clear understanding of direction and impact on them, right? So between those meetings, I also get updates and reports from the partners, and I will make sure they are circulated, and I make sure that through Lizzie, Lizzie Rich, that any feedback from those partners that see these reports, if the partners then go, oh, actually, I'd like to have we need, and if more than a couple of them say, actually, we'd like to, because we're doing, then it comes as a substantive item. So throughout the year, I have an ongoing, the chair's role and Fiona's role as vice chairman there, we work very closely together. We are managing all those things, and we only bring the stuff to the Health and Wellbeing Board that the partners need to get something from, or to get a steer or a decision from. Between that, I have an item on my agenda that says actions between arising since the last meeting. So if we've done any of that stuff in between meetings, we actually tell everybody at the next meeting, by the way, you'll all remember we did this.
Okay, thanks, Dale. Members, have you any questions? Oh dear, Dale, you're going to get off the line.
No, on to the important people. Let's get on to Grania because I think that is important stuff you're about to hear.
Okay, thank you. Then
thank you, Chairman, and thank you, members.
Thank you very much. Grania, welcome.
Thank you, Chairman. Thank you, colleagues. I think Fiona and I did have a discussion, and we decided that I wouldn't also do a presentation because the key themes were called out in Fiona's presentation. But I do intend to talk to each of the items. So from a social care perspective, if I cover sort of really from children's, young people and adults and older people as well. I think it's important firstly to note that we do not yet know the full impact of COVID on the health of our population and therefore the impact on social care. What we are observing is a higher level of demand and individuals, should we say, complex conditions being presented now in those key support services that Fiona highlighted earlier. And having a significant pressure for us as a council. It's really important that we find a way of supporting all of the people, our residents who have a need for our care and support, direction, and just wanted to indicate that we do need to be focusing on our partnerships and strengthening them further, especially recent discussions that we've started around how we support those vulnerable people who may not meet that threshold for services within social care, who we've done a grand job supporting throughout the COVID period and who we now need to ensure with our multi-agency partnerships that we do support. So we are focusing on that and making sure that we collectively as a system are able to join up all of those supports that we're already offering. So in terms of the thinking about social care and the impact, the key points I just want to raise are people may or may not be aware that in March last year, the government changed the statute for discharging people from hospital. So in the past, people will have seen in the press and the media that social care generally only gets mentioned in a health perspective when we're blocking beds in hospitals. And so that has been the historic media narrative. But we provide so much more than that in terms of supporting people to return home where we can, supporting people, families, to make sure they make the right choices at the right time for what's right for individuals as they've had a health crisis and they need to make sure that they're supported appropriately. And so previously people would remain for longer in hospital whilst we undertook an assessment of their need. And then once they were ready for discharge, they would then come out of hospital. There's lots of evidence and narrative to suggest hospital is not the right place for a frail older person once there is no longer a medical intervention to undertake, reduction in muscle mass, reduction in bone density, etc., ability. So it's really important that we do get people out of hospital as quick as possible. So from March last year, something called Discharge to Assess was implemented across the board. So people are now moved out of hospital and they are then assessed for their future needs out of hospital. Now, during the COVID pandemic, a lot of that out of hospital was within our integrated teams that you've already heard about, so social care and health working together, but also in residential and nursing homes. So people were moved quickly out of hospital to free up capacity in the beds, but also to actually make sure that people didn't stay in hospital for longer than they needed to because of all the risks associated with being in the hospital when they didn't need to be. So that has continued through this whole period, and we've been able to meet the demand, so support people appropriately during that period of time, supporting people to have rehab, to have physio that they needed, to have a little bit of reablement, people improving as far as we could back to their previous health conditions where that was possible and remain in the community. It is becoming increasingly difficult now. So we are now beginning to see an increased level of complexity with those individuals. So when we actually, how much support does somebody now need once they've finished an enablement period and finished all their rehab? People's conditions are more complex, so they're not getting back to the level of function that we've seen previously. An increase in people needing complex care packages, some people needing support for often two people providing that care and support. We've got examples of living care. So a whole range of different types of support services to support those individuals to remain in the community. So what we are seeing is during COVID, I think Councillor Burge mentioned about people not accessing, services in the same way because of not wanting to put pressure on the system, people not attending appointments because they were worried of catching COVID as well. And so those individuals, a lot of those have been isolated, haven't been as mobile, haven't been connected to their communities as they previously were, and having all of that psychological, cognitive interaction and that well-being uplift of seeing people and engaging does have an impact on health. And we are seeing now a significant reduction in the health of a certain proportion of our population coming through in terms of how we're going to try to support people. So from I'll call it frail older people, but older people with long-term conditions, there has been seemingly a marked deterioration in those conditions coming through the system for us to support. Another area of significant change for us and how we interface with the health system that Fiona described was about mental health. So across the board, I don't know if people saw the news item on the BBC that COVID and mental health, the silent pandemic. So across the board, we're seeing that. So we've seen it across South East, seen some of that in Bracknell, increase in referrals to adult mental health services. Obviously, we in social care support part of that for people. People presenting in acute crisis in the way Fiona described, as well as people being supported to access those lower level services as well, but an increase in number of people. Older people with dementia and complex dementia, significant increase in those referrals and the support we're providing to those individuals, increase in safeguarding, especially in the older people, dementia pathways. Arguably, reduced levels of input and eyes on people, as I described them, during that COVID period. So we are now seeing increase in safeguarding referrals for older people, mental health, and primarily dementia. And let's not forget about the massive impact on young people's mental health, which we're beginning to hear about across the board. And a lot of that is, as Fiona described, presenting in primary care with our GPs. So young people's mental health is something that we should all be worried about, and how we're working together to try to support young people, families, etc., to get the right access to the services they need at the right time. And with all the pressure in the system, that can often be difficult to achieve in terms of young people's mental health. In terms of primary care, you may have heard previously, I'm not sure what over in Scrutiny have looked at, but around primary care, we are trying to work increasingly in an integrated fashion with our GPs and with our other health partners to try to provide more coordinated support around individuals. And I think that's going to be vitally important as we further design what that's going to look like, so we can get to people earlier. So we do have a prevention duty within our statute that we operate within Adult Social Care, the Care Act, and we do have a wellbeing duty. And we just need to make sure that we're all working with our partners to make sure that those services that are available within those communities are sufficiently robust to support people to remain in those communities for as long as we can support them. So primarily the pressures we're seeing is significant increase in demand across the board, primarily due to increasing complexity across all services. We've got a way of working with our health colleagues for discharge from hospital, but something that I won't discuss tonight because of time, but we do need to think about the future funding of that arrangement, because people now come out of hospital when they're not as well as they were before, and government need to come up with a decision on how that's going to be funded long term, which we're hoping is going to be resolved through the adult social care reform that's currently in debate within Parliament and the government agenda. The other area, the only one I'll mention, is that we've also had an increase in referrals to our drug and alcohol teams. The first 6 months this year compared to previous year, there's a 31% increase in referrals. And that links with the alcohol-related harm that we're seeing communicated, and 24% increase. I recall seeing on one of the readings somewhere. Can't remember the source data, I do apologise. But we're seeing some of that start to turn into people requiring treatment. But equally, we've got really positive outcomes, successful completions for treatment, both in drug and alcohol, of those people going through the system. So there are significant positives, but there has been a significant increase in demand from a social care perspective on that interface, and in the way the way that Fiona described this significant demand that started to emerge or that is present in the system. We are seeing the other side of that in terms of how we're needing to respond within both adults and children's services.
So much information. I think the big piece of information is, of course, is we don't know what the future holds in terms of, dare I say, quantity of these ailments, all around, not just the young, the old, everywhere. I think it's still to be seen. Members, do you have any questions? Councillor Mrs. Mattock.
Thank you. Hope you can see me this time. Thank you. Just really it's about a particular hospital and about two friends. Last September, a friend had a heart attack and admitted into hospital. Some days later, she was discharged, and a friend called round to find her totally perplexed. She had 10 different drugs to take, and she didn't know when she was supposed to take them. So I got called in. I had to phone the doctor for help because she was told the doctor would contact her, only to find that the doctor's surgery hadn't been informed she had been admitted into hospital, let alone discharged. I had to go to her home, get her discharge papers, take them up to the doctor's surgery, and then take them back. And that's the way they found. So that's one thing. A second friend was admitted on Christmas Day, same hospital, and she was in for several days. They were going to send her out, but they decided they shouldn't. She had more tests. Interesting scenario, but I won't go into that. She was then sent for rehabilitation. She was in this unit for 5 days. There was not even a television to entertain them. There was nothing. That's 2 experiences. So perhaps you ought to be aware of those.
That's really helpful, Councillor. Thank you for sharing that. And if I just give a just initial response. So as part of the hospital has to refer to social care in order for an individual to have support. So unfortunately, in the first description of the individual you described, it looks as if she wasn't referred to social care because she would have been supported. GP should have, I mean, Fiona Cumming, you know the health system better than I. GP should have access to the discharge sheets within people's records. My understanding is they transferred across, but often there is a level of uncoordinated care in the way that you've actually described. Generally, if people can go through the adult social care and intermediate care route, so if they're referred, they get the support. So the reablement staff will go into the home and they'll help them with the medication. They'll create all the feeds, but it sounds as if she wasn't referred to social care, and sometimes people are missed. So that is unfortunate. But Fiona, do you want to comment on the rehab facility? I'm not quite sure which rehab facility that might be.
No, I don't know which facility Councillor Maddock's talking about to comment on it. I don't know whether you've got the specifics. Otherwise, I am very happy to comment if I can.
Well, yes.
Can I just mention, Isabel, before you do, can we just be careful of the personal comments and direct as it's in a public place?
No.
Yeah, happy for you to email me if you wanted to.
I will have to ask her permission.
That's fine. Thank you very much.
Thank you.
And in terms of the GP not receiving the information, they obviously are supposed to receive a discharge summary, and it's usually sent electronically. So I'm sorry that didn't happen in that case, Councillor Maddock, but that should happen, and the GP should have had the information.
No, well, they didn't. So yeah, fine. Thank you.
Thank you. Councillor Templeton.
Councillor Templeton, thank you very much. Ron, you said about mental health for young people and for older people, and I think we're all aware of how this is increasing and the difficulties. There must be a huge increase in support that is needed. I'm totally aware of what Couth and also what the Youth Line does in school with face-to-face, but Youth Line have a long waiting list already before COVID. So when is this input, when is this support going to be increased? What is proposed, and how can young people actually be helped to think that they are going to talk to somebody within the next 18 months, because CAMS has always been 18 months or something? And also for older people, you know, when are the waiting lists going to go? How much input and when will it start, please?
Okay, Fiona, if you can, so thank you, Councillor. Fiona, if you can join me on the CAMS investment from a health perspective, that would be helpful. So you are right, significant increase in demand, and we're just trying to work out what that looks like and make sure that young people are at least aware of the range of options for support so that we can prioritise. And it is a challenge, especially where people are on the acute end of that mental health pathway for young people. There are, I mean, Fiona, we do engage with Fiona regularly, and Fiona is fully engaged with us in the Young People's Partnership Board, where we've been able to highlight this issue increasingly. And Fiona, from a health perspective, investment is responding. So we are aware of that issue with CAMS. We're trying to fully understand the need of the Bracknell population and what that might look like in terms of the response. So do you want to comment on the investment from a health perspective in CAMS, Fiona? Because I know you've been doing work on that.
Yeah, very happy to, Grania. So there are a couple of things going on, I think, with CAMS investment. So you've heard us talk about the early help and support offer, because I think that's a really important point to focus on, is actually a lot of our young people, if they had the help and support they needed much earlier and at an early point, and they may not end up in CAMS services. So I think that's the first thing. And you heard me mention about the mental health support workers in schools. And Councillor Templeton, that's a really important part of that. So working very closely alongside colleagues in education and offering those online and virtual support solutions, because what we know is our young people are more comfortable with that virtual offer and technological solutions, possibly, than maybe I am. So I think that's quite important. I think in terms of young people who have a need for accessing mental health services, we've put a lot of investment into CAMS services, both the routine CAMS offer, also services for children with autism and autistic spectrum disorders or ADHD. So we have put well over £1 million in for this coming year to help address some of those waiting lists that you talk to, recognising that we need to do something about that, but also investment into crisis services, so into the hospitals locally to support discharge, and also wraparound support to help children, young people, and importantly their families and carers, to support that young person so that they can stay at home and be cared for within their own community. So there's a huge amount of work going on across a full range of services. And as Gráinne's mentioned, we work very closely with partner agencies, but also other health partners, because there's a broad range of services that are available to support, and the voluntary sector and third sector, so we work alongside them very closely. But you know, lots of work still to do. I won't deny that. So a huge amount of work still to do, but a lot of really good work that's happened over the last year. Thank you, Chair.
Thank you. Councillor Jill Birch.
Thank you.
Thank you, Chair. I'm actually very interested in mental health. It'd be quite useful if we could have some up-to-date figures actually about the number of referrals and the waiting times, if that's possible in the future. I think it'd be very good for us to look at that. My question is actually about discharging the older generation, and I'm just going to ask if that's possible. You won't be able to answer it tonight, I think, but could we have figures about readmittance? This is an area that really is something that I think as a scrutiny we should really be aware of, and we should keep a real eye on, is when people are discharged and then they have to be readmitted quite quickly again. And I would like to sort of have that as something that we could look at, to be honest. So I don't know whether Gráinne and Fiona, you'd like to answer that, and perhaps we can have some figures sent to us. I wouldn't mind a comparison between pre-COVID and post-COVID, just to see, you know, how it's, you know, what happened, whether it's become worse or better, or how we're dealing with it.
So Chair, Councillor Birch, so it's something that's monitored through the CCG, but we do have access to some of that data as a partnership. Obviously, any readmittance might be due to a different condition, or might be due to a failed discharge, as in, you know, what went wrong with the arrangements and the discharge, which actually meant the person then needing to be readmitted. So there's data on both from recollection, or should be data on both of those available. So Fiona, that sounds as if it's something that can be made available to the committee. Yeah.
Yes.
Would that be possible to come through the chair? Would that be emailed to Rob?
Yeah, Fiona and I will sort that out, Chair, Councillor Birch.
Okay.
Thank you very much.
Thank you. Members, I'm not seeing any other questions. No. Then I think it just falls to me to say thank you very much to our three visitors this evening, and for your time and the information. We're all, as I said before, we're all gone away a lot more educated, and I think also, I think we can give more comfort to residents when we're in discussion with them about some of these subjects. So again, thank you all very, very much for coming along.
Thank you, Chair.
Thank you, Chair.
We then...
Thank you, Chair. Good night.
Thank you very much to all of you.
Good night. We now move back into the Overview and Scrutiny Commission, which is item 6 on the agenda, and it's the minutes of the previous meeting on the 8th of July. First of all, does anybody have any points to raise? No? Then I would move acceptance of those minutes if I can find a seconder.
I'll second it for you, Mr. Chair.
Thank you, Councillor Virgo. Is there anybody of a different persuasion other than accepting the minutes? Please indicate. No, then I take it that we have indeed accepted those minutes. We move on then to item 7, which is to note and to confirm the appointment of Councillor Mrs. Mackenzie to the Wellbeing and Finance Overview and Scrutiny Panel, following the nominations made at the Council on the 14th of July. So, Pauline, congratulations. I hope you look forward to, I think, an awful lot of work.
Thank you, Chair.
Welcome. Move on to item 8, which is the Environment and Communities Overview and Scrutiny Panel Report on food waste in HMOs and flats. Councillor Porter.
Thank you, Chair. It gives me great pleasure to introduce the Environment and Communities Overview and Scrutiny Panel Review of food waste in flats and houses of multiple occupancy. Next slide, please, Kirsty. Thank you. Reasons for our review was protecting and enhancing our environment is one of the 6 strategic themes listed in the Council Plan 2020 to 2023, with the key objectives detailed in our climate change strategy. After a very successful rollout of food waste in households, there was an ambition to reduce food waste going to landfill further by implementing food waste into flats and houses of multiple occupancy with bulk bins. At the start of the review, it was actually discovered that Bracknell Forest don't actually have any HMOs with bulk bins, so it made our review focus solely on flats. A comprehensive review was undertaken, including consultation with experts, and particular consideration was paid to what impact these additional collections would have on Bracknell Forest's recycling rate and the financial viability of an extended scheme. The approach the panel took was to hear evidence from Julia Bragg from Waste and Resources Action Programme, or commonly known as RAP. Sorry, Gemma from RE London, so I can't remember her surname, but Gemma from RE London. Managing agents, Kim Shaw from our waste contractor Suez, and Bracknell Forest Council officers, including Damien James, our Assistant Director for Contract Services, Claire Pike and Donna Cox. Evidence was also given by Councillor Dorothy Hayes, Executive Member for the Environment. Site visits were conducted by members to typical flats to assess suitability. And on those site visits, we certainly saw the very good, and the ugly. I'd like to take this opportunity to thank everyone who took part in the review, as well as the panel for their contribution. I'd also like to give special mention to Emma Young, our governance and one of our governance and scrutiny officers, for all her hard work in keeping us in check, making appointments for the businesses, and helping to produce a comprehensive and coherent report. Next slide, please, Kirsty. The panel initially wanted to implement food waste in all flats in the borough. However, following consultation, this was found not to be feasible. Evidence was from experts was unanimous about the challenges in collecting food waste from flats, and this was further highlighted by the panel's site visits, as previously mentioned. As this slide shows, food waste from flats is on average significantly lower than in households. This is particularly due to low participation rates and poor facilities. Further to this, there would be a significant cost implication to a full rollout, which would not result in much of an increase in food recycling nor recycling rates. Next slide, please, Kirsty. There was quite a few potential challenges: cost, low participation, space for bins, hygiene and contamination. And unfortunately, the majority of these would be difficult or impossible for the council to influence, and efforts to improve these in London boroughs had not been successful. However, there was a number of things that could be done to increase uptake and feasibility, such as regular cleaning, clear signage and continued communication. Next slide, please, Kirsty. The panel found that the recycling of food waste in flats was most successful when the following conditions were met. The panel believed these should be considered when identifying suitable flats. I'm not going to read through them. Hopefully members can read, and I'll just let you take those in. But we all agree that these are very significant. Next slide, please, Kirsty. So going on, the recommendations from the review to the executive. Number one, that the executive implements a progressive rollout of food waste collection for up to 20% of properties, which is basically up to 1,800 flats, with officers developing the criteria for suitable flats. This should also take into account good practice, which has been identified within the report, and a panel to be consulted on the draft criteria. The implementation of the scheme to begin in spring 2022. For some members, they might wonder why we come to the figure of 20%. The borough have to purchase another vehicle because of the excellent rollout and the amount that's being collected already. And with the additional purchase of a vehicle, it would actually only give us capacity for 20%. And that is why the 20% was chosen. Next slide, please, Kirsty. Should the recommendation 1 be agreed by the executive in order to make the rollout effective, the executive commits to undertaking the following proposed actions. Individual curbside food waste caddies be distributed to residents in appropriate flats with blocks that have demonstrated the willingness to recycle and fit within the strict criteria to begin in spring 2022. Ongoing communication and engagement with residents in flats is undertaken, and where possible, give presentations to interested parties. Bins are provided with apertures to minimise contamination where no individual curbside caddies are issued. And finally, all new HMO licences and renewals will have inserted into them the mandatory condition regarding waste storage and disposal. Any breach could result in enforcement action by environmental health. And the final slide, please, Kirsty. And the final recommendation is that the executive produces a report reviewing the rollout after 1 year, along with a report on the effectiveness and cost by spring 2023. Chair, that's my presentation, and happy to take any questions. Chair, I believe you're still muted. Chair, I can see your lips move, but you're still muted.
Yeah, sorry, is that me? You said me first. Yeah. Very interesting report, and I particularly like the fact that we went and had a look at some flats. I found it very interesting. I was going to ask you about the 20%, so I was glad you addressed that. I've got to say that your agreed criteria of good practice is quite interesting, but I tell you, one thing that I find really amazing is all the contamination. And the other thing you didn't mention was fly tipping, because what happens is people actually, because it's a flat, an area of flats, what they come in and actually they get in and they just leave stuff. I have a lot of problems with flats in my ward where people fly tip, or the other people in the flats, they actually put things in their bins and it's not done properly. So I think this is a huge problem, if I'm honest. And I think that you've highlighted it really well, that actually getting a system that will actually be workable in these flats is really difficult. I was going to ask you why you were going to have individual caddies, because, you know, if you've got a block of sort of 40 flats, how can you have 40 individual caddies or 20, whatever? How was it cut out? You know, how will it work?
Okay, thank you, Jill, for that. Individual caddies is to very small blocks of flats, not to blocks of flats with maybe, say, like more than 9 flats. But that will come down to the criteria, the strict criteria that we're introducing. There is talking somewhere. The flats we looked at was a block of 4 flats, and all 4 flats had not only there was actually 5 blue recycling bins and 4 garden waste bins. So that type of block of flats would be very would fit into the strict criteria very easily. A block of 35 flats, if they had very good dry recycling rates, they would be the ones that would have the normal 140 litre bins with the aperture to try and stop a lot of contamination. The ugly that we talked about was a block of flats whereby there's a lot of contamination within the dry recycling, and therefore when the trucks turn up to empty them, they normally reject them, and it's down to the managing agent then to make sure that they come in and get the bins empty themselves. So that's cost to the managing. So we're not looking at supplying individual caddies to major blocks of flats, maybe up to a maximum of probably 9 flats, I would imagine. But again, that officers to come with the criteria of how many flats they would issue. It's whether or not there's enough space as well where the caddies will be collected from, and therefore there would be work conducted with SUIs to ensure that there was an ample space for the trucks to pick up those caddies, and it didn't look a slightly mess.
Okay, I think, to be honest with you, it seems very complex, and because I have lots of blocks of flats in my ward, and I can't think of many that would actually take this, to be honest. And I've got quite a few thousand. I've got quite a few flats. So I was thinking, you know, when I read through this, how many of my flats would actually be able to cope with this. And also, I tell you, so I'm wondering whether further work needs to be done on this. A lot of work has been done, but whether a little bit more, because it worries me actually how many flats, particularly in my ward, could ever do this the way it's been proposed at the moment. I think there needs to be more work.
But the strict criteria that we're introducing is based on the dry recycling rates that we're already achieving within certain blocks of flats. And actually, I believe that the amount of flats that we could collect from have very good dry recycling rates is actually more than 20%. So it's like, say, some of the flats won't actually get the food waste, even though they probably fall into the criteria. So it is based solely on the expertise of our officers and the dry recycling rates. There are the flats within other wards whereby they have excellent recycling rates. So we're hoping that some of the blocks of flats that aren't producing very good dry recycling rates might be named and shamed, or at least shamed, and maybe the peer pressure of increasing and making sure that they do the recycling properly so they can have food waste might actually make a lot more residents in flats actually take a little bit more pride, or at least make sure that residents that aren't following guidelines do such guidelines.
Thank you. I thought that the potential challenges, the way it was put in your report, was excellent. But I also wanted to ask about developers. You do mention that that you wanted to ensure that residents would have adequate facilities, but you weren't able to meet with any developers or see how they're actually building this in the report, because that is a really big, because we've had a lot of flats built in the centre of Bracknell, over the last year, 18 months. And it worries me that we're not actually thinking enough about waste.
When it comes to flatted developments, we can actually impose conditions on the size of recycling. With health developments, we don't have any influence, but with flatted developments, we certainly have the criteria and to insist on areas for recycling. And they have to then make sure we then get in consultation with our environmental team, who will then actually put in how the vehicles are going to get there to collect all the waste and the recycling. So with flat development, we will certainly have the power to make sure that is as we want and not as a developer wants.
Okay, thanks very much, John. Anyway,
Thank you, Jill. Thank you, John. Before I move on to Councillor Virgo as a question, I think, Kevin, you wanted to comment?
No, Chair. I was going to simply just say from the Statutory Scrutiny Officer, we support the recommendations. I think as the Director, I would also say it's a really good review, but then I would say that, wouldn't I?
Okay, thank you. Councillor Virgo, you had a question.
I do. Thanks, Mr. Chairman. Yeah, I would commend this report. It's very interesting, John, what you found, to be honest. And it will help us a lot, I think, in gathering information. The only thing that I would bring up really is to bat on to Jill's point. And I'm wondering whether we should have some new planning regulations about things like this, because there are so many things now that we're looking at waste. I mean, it's not just food, but it's other things. And when we have planning meetings, I know Dorothy always brings it up, but I think we all now are aware that sometimes, you know, developers leave that bit to the last bit, and that's the bit that's really tight, and, you know, and so on. And I think your recommendations and your kind of good practice should be part of a planning condition in flats, to help Jill's point.
Okay, going on from that, Tony, we did actually communicate with Max Baker.
Yeah.
And he was the one that actually said that recommendation wasn't actually needed in our report because it's already covered in granting of planning permission for flatted development. So the planning committee and officers already have that power within the legislation. So we, you know, providing it is flatted development, the developer has to follow what the borough want. When it's household development, we don't have such joy.
No, but I take Max's point, but I still think it would be good to have specific regulations now to make sure that, you know, there's a common standard. And you've made some really good points actually about good practice, and they should apply to everything now that we're considering, frankly. But
they should, Tony. But as I said, the officer with the expertise has said that we didn't need to put it in our recommendation because it was actually one of the recommendations we wanted to put in.
Yeah.
And actually, we wanted to make the one about HMO licenses even stronger.
Yeah.
Advice taken from officers. One was, you know, we could just make with HMOs for referral to environmental health officers. But for the actual flatted developments, new flatted developments, the officer believed that the legislation already covered what we wanted to put in as recommendation.
Well, I don't want to go against Max, but I think that was worth challenging, John, and because I think this is a really important fact. And it's not only with waste, it's also with things like EVs that we're going to put in, that we need specific regulations about it. Otherwise, you know, people will twist and you know, get around it. But I would suggest that this needs a little bit more, you know, investigation as to what those regulations are at the moment, and, you know, some specific examples of the things that you found that it finds it very difficult and how those regulations are going to help. If not, we should change the regulations and do a condition.
All I can say, Tony, is if I was a chair that didn't challenge from an officer, I wouldn't be doing my job properly. And I can assure you, I challenged Max's.
Oh, I know. I'm not.
And that is the response he come back, and the recommendations went to. I believe Kevin also saw the recommendations, our initial recommendations, and our chair of the Scrutiny Commission actually saw the recommendations, and that was one of the ones that was taken out because it was already covered within the planning legislation. So, you know, all we can do as a panel is take the advice of our officers, who are the experts. We are just members who want to try and make good for our residents, but we have to do that at the advice of the officers, make sure that we are fair and consistent. And I believe the legislation that is in place already will make us fair and consistent with any new flatted development.
Okay, well, all I say is Dorothy will be on the tail of all that. So
I can assure you that Dorothy
she's on the planning committee.
She saw all the recommendations, and Dorothy was quite happy with the recommendations and didn't actually comment on the planning because she already knows that the planning of new flatted developments will have that provision. And it was also backed by Claire Pike, our Chief Officer for recycling.
Fair enough. I'll leave it there, Mr. Chairman.
Okay, well, thank you for that. Are there any other questions? I can't see any other questions. Okay, John, I think there is a recommendation under 2.1, 11 of the papers, which I'm taking you would like to move.
I would most certainly like to move that, please, Chair.
And if you have a seconder?
I'll second it if you want me to, John.
Thank you.
Thank you, Councillor Virgo.
Are there anybody else who wishes to speak to the recommendations? I think, John, having been a member of your panel with this, I think you've kicked something into play here that we'll see again, and I can certainly confirm that Dorothy is in full support of the recommendation and is very pleased with the work that you and the panel did. So, well done.
Yeah, again, Chair, I'd like to express my thanks to all of the panel members. And I think when we all started out, we thought that collecting food waste from flats was going to be a doddle. And I think after our first meeting with RAT, it became very clear that it wasn't going to be a doddle and quite hard work on our hands. But I think we got a very good report with good recommendations. And again, I'd like to thank everyone, especially the officers, for all their hard work, and obviously members. But, you know, without the officers, we wouldn't be able to produce such good reports. So again, thank you to all of them.
And of course, we'll see a report after a year.
Yeah.
From the executive. Okay. Yeah. Is there anybody that does not support the recommendation? I'm not seeing anybody that doesn't support the recommendation, and I'm taking it that that is passed. Thank you.
Yeah, can I just say something? I think this report has really brought up a lot of the challenges, like it recorded, that actually it has highlighted the challenges. As John said, you know, we thought it would be perhaps easy, he said doddle, but to do this. But I think it's really important to actually note that there, you know, he's highlighted in this report, or the group, the challenges that are there, and that I particularly think the contamination of the dry goods recycling, and that, you know, I'd like that to be taken on board to the department to say, you know, this is something that actually needs to, you know, he was saying a recommendation.
Sorry, Jill, we've had the debate.
No, I'm just saying I'd like this
yeah, I know,
thing.
but you're having a second bite at the comments. I think we do need to move on. You're being crafty.
Thank you for protecting me, Chair.
Let's move on then to.
You don't need protecting from me, John.
Item 9, then the update of the work programme. Well, I think first of all, John, we've done yours, haven't we? I don't think if anything else has started at the moment.
We haven't got anything started, Chair, but I did have a meeting with Kevin Gibbs a couple of weeks ago, and our next review, as per the agreement with the Commission, is going to be looking at residential parking, and it's not going to be boring. We've got some very, I don't know, very thought-provoking ideas as well into resident parking. So I think I even astounded Kevin with one of them. So
you do pick
very interesting.
Yeah, we do give you some subjects to look at, don't we? And agree.
Oh yeah. But you know,
okay,
it's very interesting and it's good for the residents.
That's good. Jill, have you got an update for us?
Thank you, Chair. The monitoring of the care levers review is just about finalised, and that now will go to the September Commission. So that's on green now. The SIL review, we've hit a couple of hiccups with the holiday. With July and August is pretty tricky to get people. We've actually done a survey that's gone out to the parishes and towns, and we've actually had some of those back, but not all of them. And we're currently getting our next meeting the first week in September, where hopefully we'll do the last few things, and then hopefully we will actually cut to the October Commission meeting. So that's where we are with that. And we're going to scope the next, because we're almost finishing SIL, we're going to actually look at to our next review, which will be SEND, and we'll start scoping that in September.
Thank you, Jill. And the other panel that we have, of course, the Wellbeing and Finance. Mike Gibson is now the chairman of that panel. Mike has had to leave us earlier tonight because he had his first meeting and he had a commitment, as I mentioned earlier. But just to say that they are well underway with the scoping of their next piece of work, which is around mental health. So the scope will be coming for your agreement at the September the 9th meeting, which is our next meeting after this. That brings us to the conclusion of this evening. I hope you've found it interesting, enlightening, and look forward to the 9th of September for the next one. Thank you all.